topic for today's discussion is hypertensive disorders of pregnancy. Now coming on to the topic which you are interested in. So how do we classify hypertensive disorder? Many classifications have come, but this is what is given by a International Society of Study of Hypertension in Pregnancy, and which is most of the times accepted. Anything, one is we divide into two phases, two parts. One is anything which is less than, say, 20 weeks. Less than 20 weeks means before 20 weeks of pregnancy or pre-pregnancy. We can have chronic hypertension. This means hypertension detected pre-pregnancy or before 20 weeks of gestation. Essential hypertension, hypertension without a known secondary cause. Secondary hypertension, when we know there is a secondary cause, for example, renal disease. Another thing is a white coat hypertension. This many times what we say is when patient comes to hospital, we measure her blood pressure and she is hypertensive, right? The blood pressure is more than 140 and diastolic is more than 90. And then patient goes home, then next time she comes, everything was normal and when I measured at my home. This is what we call as, we always think that this patient is having some anxiety because she's going to hospital, all right? So this is a white coat hypertension. We never used to take this as very serious. We always thought that is because of anxiety. But now the studies have come that this white coat hypertension patients are more prone to develop preeclampsia. They are to be monitored. Another definition is, or the terminology is masked hypertension, where BP is less than 140/90 at office, but it is more than 135/85 at other times outside the clinic. All right. So it is practically opposite to white coat hypertension. In white coat hypertension, it was more in clinic and less in at home conditions. In masked hypertension, it is normal or less in office and more in outside state situations. And the second is when the hypertension is after 20 weeks. This is one is again three things. One is gestational hypertension. It is only hypertension which occurs after 20 weeks, and there is no proteinuria or no other feature which is suggestive of preeclampsia. All right. There is a transient gestational hypertension. Hypertension again arises after 20 weeks which resolves with repeated blood pressure readings. So this is a transient gestational hypertension. Then comes the preeclampsia de novo. Now, what is the preeclampsia? It is a gestational hypertension, all right, plus one or more of the following conditions, which have newly onset, right? So this is one is proteinuria. In earlier days, what we used to have was, we have hypertension, we have proteinuria, and maybe we have pedal edema. We used to say this is PIH. But now the definitions have changed. So because all those things, only proteinuria, the fetal outcome or maternal outcome has not been very clearly associated with proteinuria, or for that matter, even in edema also. So now they have included other things also, what we call as end organ dysfunction. End organ dysfunction can be in the brain, neurological things, or there can be pulmonary edema, or there can be hematological changes, there can be kidney changes, there can be any uteroplacental dysfunction, there can be liver involvement also, or any uteroplacental dysfunction, like if we have a hypertension plus placental disruption, this means this patient is PIH, all right? We have hypertension plus we have fetal growth restriction, this means this patient has PIH. We have hypertension, we have plus abnormal uterine artery Doppler, this means this patient has PIH, all right? So anything with hypertension with any of these things or one of these things is gives us a diagnosis of preeclampsia, all right? So if we have a superimposed on chronic hypertension, anything if patient is having hypertension which was pre-existing, like prior to pregnancy, and there is development of new proteinuria or other maternal organ dysfunction, we call this as a superimposed on chronic hypertension. And last of all, convulsions or eclampsia. Convulsions in patient having preeclampsia, it may occur during antepartum, intrapartum, and postpartum up to 10 days. Many times we usually, once patient delivers, we say, okay, everything is fine, now you can go home, everything. But you have to monitor this. Eclampsia can occur up to 10 days postpartum. So this means this patient needs monitoring postpartum also. Another classification which has been given is early onset preeclampsia, that means less than 34 weeks. So this is associated with much higher risk of short and long-term maternal as well as perinatal morbidity and mortality. Another is late onset preeclampsia, that means more than 34 weeks. Then is a preterm preeclampsia. This means when delivery occurs. See, please don't try to mix up all these things. They are two depends on at what gestation it develops. These two are at what gestation the baby delivers. If baby delivers before 37 weeks, we call this as preterm PE. If baby delivers more than 37 weeks, we call this as a term PE, right? Now, what is hypertension? When blood pressure systolic is more than 140 millimeters mercury and diastolic is more than 90 millimeters of mercury, based on average of at least two measurements. If hypertension is severe, that means more than 160, more than 110 diastolic, then repeat within 15 minutes. Otherwise, repeat in at least 4 hours or 2 consecutive outpatient visits, but not more, which should not be more than 7 days apart. So blood pressure more than 140/90, or there is a change in systolic blood pressure of more than or 30 millimeters of mercury. If somebody had say 100, it increases to 130. Even we take this as a increased blood pressure. All right. Suppose somebody had say 70 millimeters of mercury diastolic. If it increases to say 85, we call this as increased diastolic BP. All right. So even one parameter is absolute, where we have 140/80, 140/90, or we have two parameters where either more than 30 millimeter increase in systolic blood pressure or more than 15 millimeter mercury in diastolic blood pressure, that comes in the criteria of a hypertension. Now, what is the correct method of measuring blood pressure? These are basic things which we as examiner also many times ask students. Once you present a case of AIH, just find out, okay, how do you measure blood pressure? And if you get stuck in these smaller things, the discussion does not move ahead. So we have to understand these smaller things also. So you have to choose a correct blood BP cuff size. Rest for 5 minutes before measuring blood pressure. Sit in a chair with both feet flat on the ground and back straight. Your feet should not cross each other. All right. Place your arm at the level of your heart or chest and stay still and do not talk as much as your blood pressure machine operates. A very interesting thing. Many times, you are taking a blood pressure and patient is talking to you. We don't, take it very seriously. But this happens because, see I'll show you the next slide. So this is how you measure. It is lowest in lateral recumbent position, which I showed you in one of the charts. And the BP of the superior arm in this position is 10 to 12 millimeters lower than the inferior arm. Remove all tight clothings. Always measure in right arm. Instrument at the level of heart, and diastolic BP to be measured at count of 5 when the sound disappears, right? Now see the small mistakes which we do. If we have improper cuff size, if it is too large, the BP decreases, measurement decreases by 2 to 10 millimeters of mercury. If we have too small size, it increases by 2 to 10 millimeters of mercury. Improper cuff placement, it increases by 5 to 50 millimeters of mercury. Talking during measurement increases up to 10 millimeters of mercury. So please do tell patient not to talk once you are, measuring blood pressure. If patient positioning is, wrong, unsupported back or improperly supported arm, feet not resting flat on the floor, arms not supported, increases by 10 millimeters of mercury. Even when, full bladder increases your blood pressure by 10 millimeters of mercury. So always tell your patient to pass urine and then take in the position which we described, right? So coming on to the chronic hypertension, this means the patient had hypertension which was pre-existing, that was pre-pregnancy, or what we'll do now. So you do all the basic tests. Why? Because tomorrow you should have some basic things with you in case patient develops superimposed preeclampsia. So if you have base levels with you, so that is important. No? So do a urine microscopy and urine protein excretion, protein creatinine ratio or albumin creatinine ratio can be done. Full blood count for platelet count and hemoglobin, serum creatinine, and liver enzymes. Additional testing can be performed if the abnormalities are detected, such as other. If you find any abnormality in these investigations, then you can do other electrolytes, renal ultrasound, maybe LDH and blood film for schistocytes if hemolysis is suspected, or maybe 24 hours urine collection for proteinuria and serum albumin if nephrotic syndrome is suspected. Coming on to the white coat hypertension, which I described earlier. So initially we thought that this, it has nothing to, should not be worried because this patient, when it comes to doctor, only then it increases because of anxiety. And we usually take it lightly and send patient back home. So a patient, Pinky, 28 years of age, married for 1 year, presents with 2 months pregnancy. On examination, blood pressure is 142/94. Pulse is 100 beats, BMI is 25, urine normal, mean arterial pressure is 110. What do? Repeat recording after 4 hours, okay? Ask for any family history of hypertension or preeclampsia. History suggests of renal disease. White coat hypertension is a form of labile hypertension. When in office, I explained that. So it is seen in 13% of population. It is not associated with tachycardia. Patients are not necessarily old and do not respond to pressor substances. Morbidity is higher than in normotensive. That is why the importance of this white coat hypertension has come. So nighttime BP is a stronger predictor of adverse outcomes than daytime BP. All right. So let's see what are the maternal outcomes, maternal and perinatal outcomes in white coat hypertension during pregnancy. Preeclampsia relative risk increases 5.3-fold. SGA means small for gestational newborns. The risk is 2.47 this time. So worse perinatal and maternal outcomes than normotensives, but better than a gestational hypertension. And this means this white coat hypertension is somewhere in between these two situations where we have normotensives and say gestational hypertension. So white coat hypertension somewhere in between these two things is there. All right. So what do? These women would require monitoring for developing preeclampsia, small for gestational age babies, and preterm birth. Now, do these patients need monitoring? Yes, these patients need monitoring, but do they require treatment? No, they do not require treatment unless the patient develops sustained hypertension or any evidence of cardiovascular disease or signs of target organ injury. How do we manage? They have to be managed at regular home monitoring or ambulatory monitoring can be done, and antihypertensives are avoided till BP is elevated on home monitoring. Some people suggest that these patients, some studies suggest that these women require aspirin prophylaxis. So this is one of the indications of giving aspirin. If we find white coat hypertension, you can give aspirin, initiate from 12 weeks and continue till delivery for prevention of preeclampsia. So clinical application of this monitoring. We do a 24-hour ambulatory monitoring. If awake blood pressure is less than 130/80 and sleep blood pressure is 115/70, This means diagnosed white coat hypertension. If awake, and this is more, this is a chronic hypertension. Again, the risk of gestational hypertension in these patients is 50%. PIH is 8%. They require monitoring for remainder of pregnancy. All right. Coming on to the gestational hypertension. This hypertension, which develops de novo after 20 weeks of gestation in the absence of proteinuria and other findings. This means only hypertension is there. We call this as a gestational hypertension. All right. About 25% of women who present with gestational hypertension will later on progress to preeclampsia and have poorer outcomes. So once we find that there is a hypertension, we still have to monitor and get investigations at frequent intervals that patients may not develop symptoms of preeclampsia. Okay. Now, suppose a woman presents for antenatal care at more than 20 weeks without knowledge of her prior values, and she is found to be hypertensive. How should she be managed? She should be managed in pregnancy as if she has gestational hypertension or preeclampsia unless or until the balance of evidence shows otherwise. This means anybody who comes to us after 20 weeks, whether she is found to be hypertensive, please treat her as gestational hypertension or preeclampsia, or later on, if you find something, some previous history that she had hypertension, prior to pregnancy, then maybe a chronic hypertension. Otherwise, they are to be treated as gestational hypertension or preeclampsia. How should she be investigated? She should undergo investigation for preeclampsia to rule it out. Now, coming on to angiogenic markers, if available, could be performed. If normal, the diagnosis of gestational hypertension would be strengthened. Fetal ultrasound, where available, should be performed to assess fetal growth, amniotic fluid volume, and umbilical artery Doppler. I told you these are another end organ changes. If any of these is important present, then it goes on to PE. Otherwise, it remains as gestational hypertension. All right. If FGR is detected, we do manage FGR, as that we come to in the next lecture day after tomorrow. How should she be followed? She should be followed intimately at least once weekly. This is the question many times examiner asks you. How frequently do you call this patient of gestational hypertension? We call her every, at least once weekly. Proteinuria testing at each antenatal visit means every week. This means every week. Or we can call her early if any of these things develop. Patient has visual disturbances, headaches, chest pain, dyspnea, vaginal bleeding, or if there is systolic blood pressure is increasing, if on self-monitoring, dipstick proteinuria if self-monitoring, pulse oximetry if self-monitoring, any problem, then she can come early. Otherwise, she will come every week. Okay. Now, how frequently ultrasound is done? At least monthly. Right? And what do we see? We see the fetal growth, amniotic fluid volume, and umbilical artery Doppler. If preeclampsia is again suspected on clinical grounds, the woman should be reevaluated for preeclampsia. Now, assessment of proteinuria in hypertensive disorders of pregnancy. What we have discussed was, we discussed about the hypertension. The second important thing is proteinuria. Now, how do we assess this? This is what gold standard is 24-hour urine if it is more than 300 milligram per day. Many studies now are telling that this particular investigation is not important, but still we find that this is important because it also helps us in diagnosis of nephrotic syndrome. So this 24-hour urine is important. In case it is not possible to do these things, then probably your dipstick screening is okay. And if dipstick is 1 or more positive, then please use albumin creatinine ratio or protein creatinine ratio to quantify proteinuria in pregnant women. If you using protein creatinine ratio, they use 300 milligram per millimole as a threshold for significant protein. This is the value. And if you are using albumin creatinine ratio, this is 8 milligram per millimole as diagnostic threshold. All right. Do not use first morning urine void to quantify proteinuria in pregnant women. This is many times what we tell patients is, "Acha subah, get first urine done." Please do not use this first. This gives a wrong reading. So messy proteinuria more than 5 gram per 24 hour is associated with, this means nephrotic syndrome, is associated with more severe neonatal outcomes and earlier delivery. In earlier days, when we were students, we were always taught that if it is not this much of proteinuria, please terminate pregnancy, otherwise she will lose her kidneys also. So that was an indication for delivery. It is still, it causes more severe neonatal outcomes and earlier delivery is required. So what is gestational proteinuria? It is defined as a new onset of proteinuria without other obvious features of preeclampsia or primary renal disease. This means this proteinuria develops during pregnancy, but there is no hypertension, all right? Or there is no other feature of or end organ damage or no primary renal disease. Only proteinuria is present, and this is called as gestational proteinuria. Now, what is the importance of this proteinuria? Now, women with gestational proteinuria have blood levels of placental growth factor that are intermittent between those of normal pregnancies and preeclampsia, prompting consideration that these women may have an early form of preeclampsia. This is a new concept which has come. If only we find that there is a proteinuria, please do not ignore it. This patient may present to you or may develop preeclampsia later on. So this is one of the early forms of preeclampsia, what we call as a gestational proteinuria. Now, recommended approach to management of these women is to consider 3 possible outcomes. One is no preeclampsia will develop throughout pregnancy and proteinuria disappears postpartum. The second is proteinuria turns to be first symptom of preeclampsia and these patients will develop blood pressure subsequently. All right. Third is proteinuria persists postpartum and ultimately signifies a primary renal disease. So 3 situations. One, it disappears, finished, no preeclampsia develops. Second, preeclampsia develops. Third is proteinuria exists. And then we have to think that she may be having a renal disease, right? So it is recommended to monitor these women more frequently than usual for the remainder of their pregnancy, as well as to assess proteinuria at 3 months postpartum. So 2 things we have discussed: hypertension and proteinuria. Now, this is the definition of hypertension, proteinuria. Right, this is what we have discussed. Now, what is the incidence of preeclampsia? It is 5 to 15%. Primary gravida, it is 3 to 10%. In multigravida, it is 5%. Another classification which has been given by ACOG is severe and non-severe. NICE has given divided into mild hypertension, moderate hypertension, and severe hypertension. If systolic BP is 140 to 149 and diastolic is 90 to 99, is called as mild. 150 to 159 is moderate. Severe is more than 160 and more than 110, right? So, but most of the times it is now described only in 2 things: mild and severe. We have blood pressure more than 160, 100, less than 160 and more than 160. Diastolic less than 100, more than 100. Proteinuria less than 2 plus. It is persistent more than 3 plus. Headache is present here. Visual disturbances are there. Abdominal pain can be there. Oliguria can be present. Patient may have convulsions and eclampsia. The liver serum creatinine is increased. Your thrombocytopenia occurs. There's liver enzymes are increased. Liver enzymes may be increased in mild also, but they are minimal. Fetal growth restriction occurs mostly in severe form, and pulmonary edema occurs, may be present in severe eclampsia.